LTC, called the Ludwig classification. This is a woman in her 20s who's having her hair part getting wider and wider over time. This is a Ludwig stage 2. The previous one was Ludwig stage 1. And then here we have a mother-daughter duo. The mother is a stage 3. The daughter is a stage 2. And here we have a stage 3. So it can be this bad in many people as well. So we should be aware of the different stages. This is a 22-year-old girl showing significant loss. Note she's retained her hairline in this photograph. And frequently we get the Christmas tree formation, where we get like a triangular formation of hair loss, where you get worse as you go more toward the front of the scalp. Male pattern hair loss, we're all familiar with the Norwood Hamilton classification. This is an 8-year-old boy who started out with male pattern hair loss. This is a typical case of stage 3V, V meaning vertex involvement. This is a 3V going on to a 4. Note there is a bridge over here. We call this the bridge over troubled waters. And it goes away as you go from 4 to 5, 5 to 6, and then this is a 6, and this is a 7. So you can see the different grades. And sometimes this was a 15-year-old boy showing a female pattern of hair loss. And this is a 60-year-old woman who showed a male pattern of hair loss. So you can have overlap. I wrote an article in the British Journal of Dermatology. I'm sorry, this was in the New England Journal of Dermatology quite a few years ago, and it goes through hair loss in women. You may find it useful. We've also published quite a bit in how to diagnose patients in the Blue Journal, the Journal of the American Academy of Dermatology. And what we talk about is the most common form of alopecia in men and women is androgenetic alopecia, where the anagen phase, the growing phase, decreases, the proportion of telogen hairs increase, the hair gets thinner and finer, the time between shedding and regrowth increases, and the scalp becomes more visible, and you get vellus-like hairs. 38% of women are affected by this condition and is the leading diagnosis in hair clinics. There's the CAR test, where you can actually look when you can assess the patient, whether there's regrowth, you can actually see small hairs growing in. Then there's the pull test, where we can actually pull the hairs and see how much hair is coming out. This tells us how active the condition is. And then we also like to look at the hair with trichoscopy, as you can see here as well. So we can examine the scalp magnified 70-fold. And there are devices, the Foloscope from Korea, the Photo Finder from Germany, and now a new device which has helped me a lot in my clinic, where there's artificial intelligence. We put this device on the scalp, and within 90 seconds or less, you can get the number of hairs per square centimeter and the width of the hairs. And you get a whole graph of what's going on, and you can quantify. And now that's the way to go, is artificial intelligence. We just bought 3 machines at New York University. We love these machines so much. What kind of tests do we do in women losing hair? Well, we want to make sure their TSH, ferritin, vitamin D, and zinc are all normal. And if we feel they have irregular periods or signs of androgen excess, such as hirsutism, we'll do free and total testosterone. We'll do a DHEAS and a 17-hydroxy progesterone as well. So these are other tests that we do if we think they're androgens. Now, if we feel that, like the tests, we talked about TSH, we're talking about ferritin, zinc, vitamin D, also free and total testosterone, as we discussed. And if we feel that they have lupus, then we do anti-nuclear antibody complement levels. We may even do an ESR. Now, how do we make the diagnosis if we're not certain? A biopsy. We take a 4-millimeter biopsy on the most active area. We send to an experienced hair dermatopathologist, and then we stitch it up. And, we have to make sure patients don't have telogen effluvium, which is another type of hair loss. So we don't want to mix up the two, and patients can have both. So you should know that, in your differential diagnosis, think of telogen effluvium from medications, psychologic stressors, nutritional problems, hormone problems, autoimmune problems, and then the central part may be widened also in this condition with bitemporal thinning as well. And the pull test many times is positive. And telogen effluvium may unmask androgenetic alopecia and may be the first sign. So keep that in mind, the unmasking of androgenetic alopecia. And frequently we use topical minoxidil to help prolong the anagen phase. Now, what are the things we're looking for? Again, iron. It may control DNA synthesis, and that's why that's important, because we need that DNA synthesis for the hair to grow. Vitamin D, zinc, all these things may be important to check on these individuals. If a patient is on an ACE inhibitor for blood pressure, like captopril, that can form a complex with zinc and may reduce their serum levels. If they have any of these problems, we then give them a supplementation, a vitamin D supplementation. All is listed here as to how much to give in terms of daily supplements if they have the problem. What about biotin? Do I use it? I don't use it that much. I feel that biotin may be deficient in trichorexis nodosa or alopecia induced by the use of valproic acid or the excessive ingestion of raw eggs. Otherwise, we don't really feel biotin is a major factor in androgenetic alopecia or hair loss in most people. Now, what about platelet-rich plasma? We do use it. We use the platelets and we use the plasma, and then we spin the blood down, and we try to get certain growth factors, and we inject into the scalp. So the platelets have growth factors, and what we do is once you inject, the growth factors come out of the platelets, and then the growth factors bind to receptors on the hair follicle called the bulge stem cells. And we did this study just published last year, which were the most important growth factors that were relevant. And we looked at different concentrations of platelets, and each person has a different concentration. If it's too low, you may not get enough platelets. And so we checked this, and for instance, in these 5 patients, we were able to get the amount of platelets, and you want a certain amount. And we looked at VEGF, our vascular endothelial growth factor, and glial-derived neurotrophic factor. And we looked at the concentration of these, and these seem to be the most important growth factors. And when we look at PD, platelet-derived growth factor, there was a high amount of it, but those patients that had high amounts, it really didn't make much of a difference. And when we look at a plot, we found that GDNF, or glial cell line derived neurotrophic factor, and VEGF were the most important. And there were some people who had too much VEGF. There was one outlier. And we find that if there's too much, if you concentrate too much, the hair won't grow either. So there is a window where it's important. So these were the 2 factors we found important. So how do we do it? We spin down the blood. It's already approved for FDA for knees. So we need more large-scale studies. We need to have standardized ways of using PRP. And so we used here the Regenelab kits. And so there are other kits as well. We're just used to this one. And I think that is something that needs to be studied more. We never use PRP on someone who has a skin cancer on the head because we may promote it. Now, we already talked about the patterns of female pattern hair loss and the blood tests that we do. What are the treatments? Minoxidil, we're all familiar with that. However, people can get hypertrichosis, itching, contact dermatitis, and you may experience increased shedding in the first 6 weeks. What about finasteride and dutasteride? Off-label use. We don't use it in women who are pregnant, and if they're potentially pregnant, we have to be very careful if we're using these. And this is for women. We use 2.5 milligrams per day, dutasteride 0.5 milligrams per day. Spironolactone is another option, 100 milligrams twice daily. And there are side effects with it, such as menstrual irregularities, and we need laboratory exams just to check their kidney function and liver function as well. This is an algorithm that we produced in our paper. If patients have less than 20% scalp involvement, consider 5% minoxidil solution, low-dose oral minoxidil, finasteride 2.5 milligrams daily, or spironolactone or bicalutamide. If there's improvement, review every 6 months. No improvement, go into this box, which is 20 to 50% scalp involvement. Again, 5% solution or foam, minoxidil, finasteride, low-dose oral minoxidil, spironolactone or bicalutamide, and then we might consider PRP. If there's improvement, review every 6 months. No improvement, we increase the finasteride to 5 milligrams daily, spironolactone to 100 milligrams twice daily. Bicalutamide we may use, dutasteride in postmenopausal women, and PRP. If there is 51 to 90% involvement, consider hair transplant, minoxidil, low-dose oral minoxidil, spironolactone, bicalutamide, dutasteride, PRP, and cosmetic products such as powders can be used. If there's no improvement, consider possibly a hair transplant if the donor area is good and the recipient area is good. And always review every 6 months. Now, we always do photographs on every patient. Patients love to see the before and afters. Now, what about men? We use oral finasteride plus or minus topical minoxidil, low-dose oral minoxidil. Then we may use PRP as well, continue therapy indefinitely. If somebody is very extreme, hair transplant plus or minus scalp reduction or a hair piece. So these are how we treat men and women who have it. Now, what about microneedling? We do use it. We did a single blinded study. Half the scalp we did microneedling, and we used minoxidil on both sides. One side got microneedling. We went 1.5 millimeters deep, and we thought that caused some neogenesis and breach of stratum corneum, allowed more effective drug delivery of the minoxidil. We used the skin pen, and this is the skin pen that we used. And we basically would try to get this kind of effect on the patient, and we didn't show that it worked. However, other people in China, for instance, showed that it did work. So I'm not saying you shouldn't do microneedling, but in our hands, we did not have a good result. There are new molecules coming up that you should know about, VEGF, beta-catenin, Wnt, that more studies will be done on. Newer molecules are on the horizon, all sorts of cell therapy. Exosomes is something new, but we need more studies on that. I'd like to thank my group of that are in my NYU hair group, helping me do the research. Thank you from NYU School of Medicine.